Come on in, have a seat. So my name is Dr. Birch. I'll be administering the Cranial Nerve Exam today. Okay, how are you feeling? Okay, you're alright. A bit nervous. That's understandable, but really, I'm sure it's gonna be fine. Yeah, I know that was quite a tumble that you took and obtained a trauma to the head, and that's why we're doing this today, the cranial nerve exam, just to see if any of the nerves have been damaged, if all your bodily functions work as they should be. So we'll go over everything in detail once we get to it. First, I just want to get a few of the formalities down, if that's all right. Okay. I know we have all your personal information on hand, but it's important to check it at the start of the test anyway. So can I get you to state your full name and date of birth? Okay, that's good. Okay, and the incident occurred when? Okay, and where was this? Right. Okay. And just in general, very briefly, do you feel that you had any, that it's affected your abilities in any way? You're not sure. That's fine. It's normal there are lots of things on your mind after you've experienced a trauma, but we'll go over everything once we get to it, okay? Good. So, a cranial nerve exam. Have you ever had one before? You have? Okay, that's good. So, you have some idea of what you're getting yourself into today, okay? So that's good. Though you did suffer your trauma, so we're gonna go over everything in probably a bit more detail than you're used to, okay? So we're gonna go cranial nerve by cranial nerve, one at a time, and testing them all, quite thoroughly. Okay, so in general, just to give you an overview of what's going to happen today, where there are 12 pairs of cranial nerves, all located inside of the brainstem, controlling different parts of the face, supplying motor information, meaning to muscle information to move different kinds of things around, and most importantly, or what we mostly attribute to the cranial nerves, is sensory information. So that's things like sight, hearing, smell, touch, and stuff like that. Okay, so the nerves that we'll be testing and going through are the olfactory nerve, that's cranial nerve 1. That's the nerve that's responsible for smell. So we'll be doing a smell test for that. Then we have the optic nerve, which is responsible for your vision. So we'll be doing a vision test using the Snellen chart and various other tests related to your vision and possible changes in your vision. Okay, and then there are 3 separate nerves that have to do with eye movement. That's the oculomotor, the abducens, and trochlear nerve, respectively nerves 3, 4, and 6. The 5th cranial nerve is called the trigeminal nerve, and that's responsible for facial sensations. So we'll be doing a touch test on different parts of your face, and it's also responsible for the muscles of mastication or chewing, so your jaw movement. Okay, and the 7th cranial nerve is the facial nerve. That's generally responsible for making all your facial expressions, so many of the muscles that control the front, outside, exterior of your face. And then the 8th cranial nerve is the vestibulocochlear nerve. So that's responsible for two things. The vestibular part is your sense of balance, and the cochlear component is your hearing. So we'll be doing a hearing test for that. Okay? Yeah. Then we have the Glossopharyngeal and the vagus nerve. These are very closely aligned, and they have to do with your throat mainly. Okay? Then there's the accessory nerve. That's some of the larger muscles of the neck, the shoulders, responsible for turning your head, showing your shoulders, stuff like that. And finally, we have the hypoglossal nerve, which is all about your tongue. Okay? Yeah. So that was a lot of information all at once, but like I said, we'll be taking it slowly and methodically, and I'll be telling you more about each of the nerves as we come to them. But in general, does that sound okay? Okay, you're ready for your cranial nerve exam then? Okay then, well, let's get started. Now, the olfactory nerve is the first of the 12 cranial nerves that we have inside our heads. And the olfactory nerve is the one that transmits sensory information about odors into the brain. So it's responsible for our sense of smell. Now, there are different disorders that can be attached to the olfactory nerve, like hyposmia or anosmia, which are respectively reduced sense of smell and a complete lack of a sense of smell. Now, these can occur with peripheral damage to the olfactory nerve, such as rhinitis or simple hay fever, trauma to the face as side effects of certain medications. Now, if you experienced a change in your sense of smell, such that all your food tastes bitter or sour or salty, anything like that, what we would call dysosmia, that could point to a deeper underlying neurological disease, and that's something that we would take very seriously. So those are some of the things that we're testing for today with the olfactory nerve. Now, the olfactory nerve itself is actually quite interesting. It consists of a small area, about 2.5 square centimeters up the apex of each of the nostril, and it's a sort of yellowish brown mucosa that's sitting up there just off the main nasal passage or cavity. And this mucosa is, it's covered by a membrane, and then behind the membrane we have two kinds of nerve receptors. The first receptor is actually trigeminal nerve fibers. The trigeminal cranial nerve is something that we'll come back to later. But that's very sensitive to irritating substances and temperature, not unlike our pain and temperature receptors elsewhere on the body. And of course, the other receptor in the olfactory epithelium is the olfactory nerve, which is the sense of smell. So, are you ready to get started? Great. So the way we're doing this test today is something called the sniff and sticks test. Have you heard of that? Okay. It's a very simple test where I will present you with a number of felt tip pens, which are laced with different smells for different odors, and your job is simply to identify what smell it is. Now, I will present, if you can't just tell just off the cuff, then I'll present you with 4 possible choices. So this is a multiple choice quiz of sorts. Yeah. the test is very, very easy to administer. It's quick, it's painless, and it's also delivering quite consistent and measurable results. So that's why I really like it to test the olfactory nerve. Now, some say it can be a bit subjective and that there are reduced range of odors that we're testing in the sniff and sticks test, but I think for our purposes it's more than enough. And if you do present any abnormalities, we will of course do an extended battery of tests after the screen test, where you'll identify a number of smells, 12 to be exact. Then we could also do the discrimination test, where I present you with 3 different pens and you have to tell which one of the 3 is different from the rest. And there's also the threshold test, where I present pens with a increasing concentration of smell inside them to see where the floor of your sense of smell is, or the threshold. So it's the least amount of molecules that you'll be able to smell. Okay? But we will get to all of that later. First, let's just get the pens and let's get started. Okay? Great. Right here in my little case here. Now, don't be fooled by the color. They are not color-coded, although they may appear to be. So I'm just getting the multiple choice list ready here. There we go. Now, before we do the test, I like to make sure that we have a nice baseline and that your nasal passages are free and clear. So if I could just get you to occlude one nostril, like so, and breathe in very deeply through the nose and out again. Very good. And the other one, in and out. Very good. And now with both nostrils, in through the nose and out. Very good. That sounds very normal, like no blockages or anything, and you don't have a cold or anything like that. Good, good, good. Okay, so then we are ready for the first stick. So just hold it here and okay, so the first of your choices, they are orange, strawberry, blackberry, or pineapple. Orange, that's right. Just note down that. We have the second one here. Need some choices. Okay. You can choose between smoke, leather, glue, or grass. Leather. That's right. Number 3. this one you can choose honey, chocolate, vanilla, or cinnamon. That's right, it's cinnamon. Lovely. Now, number 4. Again, the choices here are chives, spruce, peppermint, or onion. That's right, it's peppermint. Now, number 5. And your choices here are coconut, walnut, banana, or cherry. Banana, that's right. Actually, a decent amount of people get that one wrong. Sometimes it can be hard to distinguish different sweetnesses from each other. Number 6. You need a break before? Very good. If you need a break or a refresher, just let me know. We have some. We usually use alcohol pads just to clear up the olfactory senses. What do you say for this one? Not quite sure. Okay, so your choices here are peach, apple, lemon, or grapefruit. Grape. It was actually lemon. Yeah. Okay, fine. Okay, number 7. So we're halfway there. For this one, your choices are licorice, wine gum, bubble gum, or cracker. That's right, it's licorice. What do you say for this one? Okay, your choices here are cigarette, coffee, wine, or candle smoke. It's coffee, yes. Are you a coffee drinker? Okay. The test is specifically designed not to use any irritating substances. I mentioned the existence of trigeminal nerve fibers inside the receptors, the olfactory epithelium, and, well, using any irritating smells like menthol or camphor that could actually activate the trigeminal nerves instead of the olfactory nerves, and we like to keep things like totally separate. So we're just laser focused on the olfactory nerve for this test, and then we'll get to the trigeminal nerve later. Yeah. So that was now number 9. Okay, some options: clove, pepper, cinnamon, mustard. No, it's not cinnamon. Try again. You had that one already. Pepper, no. It's actually clove. Try again. Yeah, okay. Well, a lot of people have trouble with that one. Yeah. It's not one of the most common spices to use in the kitchen. Now, number 10, so we have 3 left. Choices here: pear, prune, peach, or pineapple. Correct. It's pineapple. Now, number 11. Just breathe in deeply. Take all the time you need. Your choices here are chamomile, raspberry, rose, or cherry. Rose. That's right. Now, last one. Choices here are bread, fish, cheese, or ham. That's right. It's fish. Okay, so you did fine in that test. A few misses, but there always are. Now, like I mentioned in the beginning, I do want to do the discrimination test as well. So that will involve me holding up 3 pens, and you have to identify which of the one is different from the others. And these smells will be more neutral than what you just smelled. Give me a refresher. Okay, just try to take a few deep breaths. In through the nose and out through the nose as well. Okay. Okay. You good? Okay, good. Now, spread these out in a fan. Okay, which of the ones here is different from the rest? This one, green one. The orange one. Or the blue one. Again, the orange. And the green. The orange. And the blue. The orange. Okay. That's right. Do a couple of these. Okay. Again, 3 smells or 3 pens, only 2 smells. This is brown. You don't have to identify the smell, it really doesn't matter, just try to focus on which is different. This is red. And pink. Red. And brown. You think brown? Okay. Try it. One more. So one by one, this is purple. Yellow. And turquoise. Yellow again. Purple. Yellow. Turquoise. Some more yellow. Purple. Okay, one more. Okay, so we first got beige here, the orange tip. Got it. Okay, then we got gray. Black. and black. Black. That's right. Okay, very good. Now, I want to move on to the threshold test. And like I said, this is testing the threshold, or the lowest amount of particles that you can smell something. Okay? So your olfactory acuity, you might say. Now, this is the same way as before with a bunch of pens. This time the smell is always going to be the same, and it's going to be a rose smell. You had the rose before, but I just want to present to you the full concentration so that you know what to smell for, okay? Okay, so this is rose. Full concentration, okay? This is rose. Okay, so that's what we're going for. And we're starting from the bottom. So, tell me if you can smell something now. Anything at all. Just take your time and breathe deeply. Nothing. Okay. About now. Still nothing. Nothing. Okay. Nothing. Okay. About now. Anything at all? Maybe you think. Okay. Okay. Like that. Just want to go down again. When you had before. Tell me, can you smell something now? Yes. Okay. Good. No, that's fine. Gonna go one more step down again. The one you had before that. Do you smell anything here? Deep breath in. Nothing. Okay, that's good. That's great. The threshold is at 6, which is very normal. So that concludes the test of your olfactory nerve. Overall, it was a very common normal test. You showed no signs of any deficiencies or abnormalities in your olfactory nerve receptors. So, congrats. So, let's take a look at your eyes now, shall we? Now, the optic nerve is, of course, the second cranial nerve, and it's quite a fascinating one. Did you know, for example, that 70% of all the sensory receptors in our whole body, 70%, they're in our eyes? So really, the optic nerve does a lot of heavy lifting. Now, it is of course a sensory nerve, so it translates the light rays that we see bouncing off of objects all around us, translate those impulses into electric impulses and transports those into the brain, the visual cortex, where we process it as sight. Now, the optic nerve, having so many sensory receptors, is also quite a large cranial nerve, or pair of cranial nerves. Of course, all cranial nerves are in pairs. Now, the optic nerve has over 1 million nerve fibers in little bundles at the back of the eye, at the back of the retina, where they travel from the eyes all the way back, and they actually cross paths. They do a little X here, actually. Let me just show you, because I think it's quite interesting. This illustration here, let's see if you can see that. Now, here we have the right eye and one eye here, one eye there, and for each eye actually is divided into, so there's a left visual field and a right visual field for the left eye. There's a left visual field and a right visual field for the right eye. Now, these the right and the left, they cross before they reach the large cross, meaning this travels all the way, so it crosses here. This is the right, and then it crosses over to the left, and similarly the other eye is right into the middle and then to the left. So the right part of both eyes is processed in the left visual cortex, and the left part of left visual field of both eyes is processed in the right visual cortex, which is where the optic nerve ends. So this has some quite interesting implications for cranial nerve damage and where that damage might occur. Of course, damage to the optic nerve can be caused by fluid buildup inside different parts of the brain, or loss of blood flow or reduced blood flow, again in different parts of the brain, or different trauma effects, of course. Now, for instance, if there is nerve damage to the optic canal, which is the part right behind the retina, right behind the eyes, then that will result in blindness on that eye only, which is pretty simple and straightforward. But like I said, the nerve fibers of the optic nerve, they cross in the middle, or at least Some of them do. Now, and if that cross is severed, if there's nerve damage to what we call the optic chiasm, then that will result in lateral field of vision loss, meaning the left part of the left eye and the right part of the right eye. So the visual field will be quite narrow. That's one of the things that we're checking for today. Now, if there is damage to the optic tract, which is the pathway behind the cross or the chiasm, then that will result in losing either the left visual field on both eyes or the right visual field on both eyes. So yeah, that will also have quite an annoying impact on your vision. But enough about nerve ramblings. Let's talk about you a little bit. So first of all, have you experienced any changes to your vision that you've noticed? That includes loss of regular vision, loss of color vision, night blindness, any of that? Okay. How about double vision or black spots? Okay. How about side effects like headaches or ringing in the ears, like tinnitus? Okay. And do you find yourself straining your eyes when reading certain texts close up or far away after your trauma? Okay. So I think I'm gonna get a bit closer to you. There we go. And I'm just gonna be asking you to just look me straight in the eye, and I'm just gonna be starting with assessing all the parts of your eye and just looking for shapes, size, iris, pupils, blood cells. Just stare straight ahead. Symmetry, coloration of everything, and I'm gonna take a real close look at the end with a fundoscopy. But just on the surface, everything looks to be quite normal. Are you experiencing my face normal right now? Any double vision or black spots, anything like that? Okay, very good. So we have a couple of tests to test the optic nerve and any damage to different parts of it. So the first one is the visual acuity test, and well, you might have probably already tried that several times at the optometrist. Right, it's the Snellen chart here behind me that we're going to be using for a start. So let me just grab my pointer here and I'll move a little further back towards the chart, and I'll just ask you to read, or first of all, cover one eye like so. Very good. And I'll ask you to read the letters just as far down as you can go, and when you can't go any further, that's fine. So with one eye closed, E, F, P, T, O, C, L, P, E, D, P, That's right. Next line. E, D, F, C, Z, tricky, and P. That's right. Now, line below this colored line here. What color is this, by the way? Green. Very good. Now, letters here are F, E, L, O, P, Z, D. Good. Next line here. D is the plant in the way. I can move the plant. Okay, it's fine. Good. We don't know what. E, F, P, O, T, E, C. Very good. Okay, let's take the next line here. Do you want to try it, or is it too? Okay. L, E. That's right. The next one. F. Very good. O. Yes. D, P, C, and T. Okay, let's try this one. You got that very good. Here, E, O, R, L, F, C, E, O. Okay, let's just stop there. Okay, that was fine. That was very normal. Now you can take your hand down and please cover the other eye, and then we'll repeat the process. We'll go from the other side this time. So that just in case, it's standard procedure, just in case if any of our patients try to memorize the lines, and we're doing it the other way around. So it's a bit harder. Yeah. So we'll go from the top again. E, yes. Now over here. P, F, Z, O, T, D, E, P, L, D, F, Z, E, P. Very good. P, Z, C, F, D, E, and down the line, D, Z, P, O, L, E, F. Good. Now, C, E, T, O, P, F, E, D. Very good. Let's try this one down here. T, C, P, yes, D, O, F, E, yes, L. Let's just go down here on this eye as well. O, F, C E T Z O F. Okay. That's fine, no need to do the last line. I think that was as far as we went. And actually, this line right here above the red line, that's considered 20/20 vision, so no problems at all there. Now, next I'd like to assess for visual attention or inattention and visual extinction, respectively. So you'll just stare straight at me, hold my arms like this, and you will let me know by pointing your fingers indicating here, 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 or here, which finger I'm wiggling. Okay? So pretty simple. Just hold my hands here. Good. Very good. Out here. Let's assess your visual field now and the size of it, and if there are any, if you're missing any left or right parts of any eye that we might not have discovered. It's not always obvious, but if you could just cover the same eye as me, okay, and just look straight ahead at my finger. You can see my finger. Good. Now keep looking straight ahead. Don't follow my finger. Just tell me when it leaves your field of vision. Okay? Look at me. Look at me. Look at me, and say when. Disappear. Okay. Try again. Look at me straight ahead and tell me when it disappears. Disappear. Okay. Look at me. Look at me. Look at me. Look at me. And disappear. Okay. Okay. Look at me. Tell me when it disappears. There. Okay. Good. Just look at me. Look at me. There. Okay. There. Okay. And just stare straight at me. Let me know when. There. Okay. Okay. There. Okay. Okay. We'll do the same thing, except now let me know when my finger enters your field of vision. My finger. Okay? I'll be wiggling it. There. Good. There. Good. Keep covering the same eye. There. There. Now we'll do the exact same thing, except with a hand over the other eye. Okay? So we'll start by focusing on my finger, and just remember, look straight ahead at all times. Don't follow my finger around with your eyes or your head. Okay, just look at me. There, good. There, good. Okay. There. Disappears. Okay. Disappears. Me. Disappear. Okay. Okay. Excellent. Now, the same thing. I'll move my finger in towards your field of vision. You'll let me know when you see it. Okay. There. There. Good. Good. Keep covering the same eye. There. Good. Good. Okay. Very good. Now let me just get another little thing from my medical case. It's a hat pin. The tip is red. That's right. Now, we all have a blind spot in our eyes. It's a certain point, normally around here, where we simply are blind. And normally we don't notice it because the brain compensates with its amazing binocular vision. That's where it comes from, the two eyes. So because we have visual information from both right and left eye, the brain can combine them. So normally we don't notice our blind spot, but we have one, and we can find it. This simple test. Again, cover the same eye as me. Here. And I'll move it to just equidistant between us, and you'll let me know when the red tip goes invisible. Okay? And just look at me. Don't follow it, just look at me. There? Tell me when it reappears. There. Okay. Disappears. Reappears. Okay. Disappears and reappears. Disappear again. Okay. Reappear. Okay. If I move it, reappear. Okay. So what I'm doing is, by closing my own eyes, is comparing our blind spots and our field of vision respectively, and so far they're matching pretty well. So that was right around my blind spot as well. Let's try and cover the other eye and repeat the test. Look straight ahead. Don't look at the pen, just look straight ahead at my nose. And I'll move it this way. Let me know when it disappears. There. Okay. And reappears. Disappears. Reappears. Disappears. Reappears. Disappears. I can move it around. This is the blind spot right here. We're just moving the pin, but the red tip is invisible. there, and there, and there, there, between here, invisible. Okay. Good job. Now, it's time to test your color vision. Do that with so-called Ishihara plates. And they're just images or colored numbers, like scrambled in such a way that it will reveal if you have any color deficiency in your vision. Okay? So, it's pretty simple. I'll just hold this up and you'll let me know what number you see. 12. 29. 3. 74. Good. 45. 7. 73. 'Just take your time. Nothing here. Good. Don't worry about it. It's just control. About this one. 42. What color would you say this is? Reddish, purple. About this. Nothing. Just a pattern. Here. No number. Do you see anything at all? Like a certain pattern or anything? A line. Straight line. Goes around like this. Right. And the final one here. Same thing, no line, or no number, I should say, but a line. Yeah. Good. Very good. So I'm going to get a bit closer to you for the last part of the exam. This last part is a fundoscopy. So I'm going to take a small light device and I'm going to shine it really close to her eyes. And in fact, I myself am going to get right up in your face. Is that okay? Good. I'll be holding on to your temples here just for support and stability. Okay? Good. And this device actually allows me to see in the back of your eyes to check upon the optic nerve. gonna shine pretty bright. Okay, turn it on there. Okay, so just the light's gonna come in right now. Okay, now what I'm looking for with the endoscopy is checking the optic disc, the retina, and the blood vessels inside. Now I'm looking at the color of the optic disc, and it looks white, pink, and healthy. The contour is also smooth, well-defined, no blurring of the edges, so that's a good sign. Now the hole in the middle seems to be of appropriate size, and the cap-disc ratio seems to be about 0.3. That is good. And the blood vessels, but they're pretty structured. So fine. Okay, I'm gonna turn it off now. And there. How can you see all right again? Good. So that is actually it for the exam of the second cranial nerve, the optic nerve, and your vision. And overall, I didn't find any faults in your vision. You aced the visual acuity chart and your visual field, your blind spot, your visual attention, all perfectly normal and aligned with my own. And the visual appearance of your optic nerve was also tip-top. The retina was fine, blood vessel was fine, the optic disc was fine. So, conclusion, everything is in order with your eyes. Let me just move my chair a little back. I don't need to be this close to you all the time. So, let's test the movement of your eyes now. Are you ready for that? Good. Now, more technically speaking, what we're testing now is actually not just one, but 3 cranial nerves that are involved with the movement of the eyes. And these are the oculomotor nerve. You can almost hear it in the name. Oculo for eyes and motor for movements. But that's the 3rd cranial nerve. And then we've also got the trochlear nerve, which is the 4th cranial nerve, and the abducens nerve, which is the 6th cranial nerve. The 5th is the one we're testing just after these ones, but these all control the movement of the eyes, like I said, pupils, lens shape, eyelids, and that's pretty much it. Now, as opposed to the optic nerve, which is also centered in the eyes, and that's a sensory nerve, these nerves are motor nerves, or somatic efferent nerves, as they're also known. Now, the oculomotor nerve is probably the most important. At least it controls a lot of things. It controls or iterates 4 of the total of 6 muscles that kind of tether our eyeballs to the skull and control its movements. And these are the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique. And these muscles allow the eye to move up, down, and inwards towards the nose. Now, these are, or the oculomotor nerve is also responsible for the sphincter pupilla, which constricts the pupils when light is shined into them, which is something that we'll test later, just in a moment. And they also control the shape of the lens to help you focus on close-up objects, and that's called the ciliary muscle. Then we have the trochlear cranial nerve, which controls one other of the 6 muscles controlling our eyes, and that's the superior oblique, allowing the eyes to rotate down and outwards. So it's quite an intricate system that the different nerves and muscles have got going on there. And then finally we have the Abducens nerve, like I said, the 6th cranial nerve, which controls the lateral rectus muscle, which allow the eye to move outwards or away from the nose. Now, damage to any of these 3 cranial nerves can cause various problems like strabismus, which is lazy eye or cross-eyedness, diplopia, which is double vision, something called ptosis, which is drooping eyelids, and just generally having difficulty focusing your eyes. Now, we already tested your optic nerve, so I know that your vision is generally in good shape and there is no problem with your visual acuity, but there still might be eye movement issues that we haven't discovered, so we're gonna take a closer look at those. We'll just start by inspecting your pupils, especially just the general size, shape, and symmetry, left and right pupils. And they look fine to me. So we'll start by affirming that your eyes and your pupils can move in all of the 9 cardinal directions that we have. So I'm going to put my finger right here. Now your job is not to stare directly at me like before, but this time I want you to actually follow my finger as it moves around your field of vision. Don't move your head, just move your eyes. Okay? So follow my finger as it moves around. Mm-hmm. Good. And down here. That's good. You're doing great. Just follow the finger. Just follow the finger as it moves all around your field of vision. Okay, we're going to keep going for a bit. And let me know if your eyes get tired. Let me know if you get headaches, focusing too much. Let me know if you experience any double vision. Let's go a little quicker. Follow my finger around. here. Now, I'm going to come in with the pen light. Move a bit closer again. So I have this pen light here. I'm going to be shining it towards both your eyes, one of your eyes, in turns in different ways, just to inspect and measure different reflexes, mostly visual reflexes. And the first one is the corneal light reflex. So this is going to come in on both eyes, just there. And I'm just looking for the reflection of the pen light in your iris. There. And in healthy individuals, the light reflex should be symmetrically positioned on the irises. And it looks to be. Now, in a word, that could point to misalignment of the eyes or the lenses or the irises. We need to take a closer look at that, but it looks to be fine. Now, we're going to look at your pupillary reflexes. So, I'm going to be holding a hand just along your nose here. I'm going to be shining the light first in one eye and then the other eye, and I'll be inspecting both the eye that I'm shining the light into and the eye that I'm not shining the light into. Okay? Just holding here at first, pointing the light here. And watching for the constriction of the pupil's direct response. Okay, normal. Now I'm watching for the consensual pupillary response of the opposing contralateral eye. That seems to be constricting pathetically. So that's good. It's more direct. Pause, dilate, and consensual. Very good. Okay. Let's do the other eye. So, placing my hand as a shield here. First, I'm checking the direct pupillary response. Good constriction. Now the consensual pupillary response looks normal as well. Same speed, same constriction as the other eye. Let's go again. Direct. And consensual, direct, and consensual. That's good. The sphincter pupilla is working properly. So next we're going to test your accommodation reflex. Now, this is related to the ciliary muscle that we talked about earlier, which changes your lens to focus on near and far away objects. So I'm just going to be watching your pupils, your lens, as you focus on my finger. I'm going to move it right up close to your eyes. Focus on my finger, focus on my finger, focus on my finger, focus on my finger, focus on my finger. There. Good. Now the other way, focus. Focus on my finger. Keep the focus on the finger. The focus on the finger. Focus on the finger. Keep the focus on the finger. There. That looks very normal. Constriction and convergence of the pupils there. We're looking at something, straight between the eyes because of the convergence of the pupils. Now, same reflex, but different test, still the accommodation reflex. I'm going to be holding my finger right up close like this. And maybe, so start by fixating on the skull back here, maybe the nose of the skull. So focus on the skull. And when I say go, or when I waggle my finger, you'll focus on the finger, and I'm watching for a shift in fixation in your eyes, okay? So start by focusing on the skull. Now fingers, the skull, fingers, skull, fingers, the skull, fingers, good, and skull. Okay, that looks normal. Okay, let's just test the volitional saccades. I'll just ask you to look down, look at me, look up, look at me, look left, look at me, look right, look at me, look down, look at me, look right, look at me, look left, look at me, look up, look at me. Excellent. Very good. Now we're going to do the swinging light test. As the name implies, I'm going to be taking my pen light here, swinging it quite rapidly from one eye to the other. And what we're looking for is a relative afferent pupillary defect. So I don't really need to know what it means, but it's basically how the pupils constrict and dilate, both directly and consensually. So just look straight ahead, and I'm going to be watching your pupils here. Watching the dilation. That's good. Just stare straight ahead. Stare straight ahead. Stare straight ahead. Stare straight ahead. Good. So what we're seeing with that defect when present, which was not, is a paradoxical dilation of the pupil when it should be pupillary reflexes and the consensual and direct responses. That is to locate nerve damage and separate the optic nerve damage from the oculomotor nerve damage. So that, well, for example, if I shine my light in this eye and I see both eyes constrict, then I know there are no problems with either the optic or the motor nerve, or the oculomotor, either the sensory or the motor nerve, I should say. Because this eye senses the light and it responds with a motor response. If I shine it over here and there's no reaction from either eye, then that tells me it would be a problem with the optic nerve, the sensory nerve, on this optic canal right there, because we know from before that the motor nerve, the oculomotor nerve, is functioning properly on both eyes. So that's just a little fun tidbit there. Now, the final thing we're going to do is a cover test, which is primarily to test for strabismus. I will cover one eye here. You'll focus on the skull again. You're behind me. Okay? Just focus on the skull. Good. And I'll be shining a light into your eye here. And I'm just watching for any shift in fixation. I'm not seeing any. That's a good sign. Okay. Watch the skull. Or the cranium. It's fine. Good. Okay, I'm going to cover this eye. And now maybe watch the large E on the Snellen chart there. Okay. Same deal. I'm going to shine in your eyes right here. There. Okay. Good. 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 Just make a note here. Okay, so like I said, that was the last of the test for the oculomotor, the trochlear, and the abducens nerve. And your eye movements were fine, your pupillary constriction was fine, your eyelids seem to be functioning properly, there's no drooping or anything. I also inspected your any possible tilt of the head, which sometimes the body naturally and voluntarily tilts the head to compensate for difficulty of moving the eyes in certain directions, but there was none of that. So I'm pretty confident that your cranial nerves 3, 4, and 6 are working as they should be. So that's good. Now, let's test your trigeminal nerve or cranial nerve 5. Now, the trigeminal nerve being a very, very large cranial nerve is both a sensory nerve and a motor nerve. Now, the nucleus of the cranial nerve 5, the trigeminal nerve is to the lateral side of the pons in the brainstem. That's part of the brain that connects the brainstem to the spinal cord down the back. From there are two roots, a sensory root and a motor root, and these combine at the trigeminal ganglion, which then again branches out further into three different nerve bundles. One is the ophthalmic, which transmits sensory information from the forehead region up here. Then we have the maxillary, which also transmits sensory information, and that's from the cheeks, the lips, and the gums. And finally we have the mandibular, which has both a sensory component, senses of the chin and the jaw, and also the motor functions of the chin and the jaw, namely the muscles of mastication or chewing, that being the temporalis, pterygoid, and masseter muscles. Now, have you had any trouble chewing your food lately? Okay. Any changes in sensation of your face in general? Any, that could be certain paralysis or lack of a sense of touch in certain regions of the face, or any pain in certain regions of the face in general. Okay, that's good. Let me just start by just inspecting your jaw, especially, and your symmetry here. And I'm just looking for any possible wasting of the muscles, which could indicate nerve damage to the trigeminal nerve, but I don't see any. Can I get you to open and close your jaw for me? Very good. Okay, let's begin the test then. Just put on my gloves here because I will need to touch you on the face. Is that okay? Good. We're going to do several different tests here. First the sensory part of the nerve, and then following that the motor component, okay? Okay, so let me just move a bit closer, okay? There we go. Okay, so let's start by this. This is a regular piece of cotton. I get you to hold out your hand. That's what it feels like, just cotton, okay? That's what we'll be calling soft today. And I'm going to be using this to test the sensations of your face. I'm going to be touching different parts of your face, okay? So can I get you to just close your eyes and say yes when you feel me touching, okay? Okay. Yes. Yes. And did that feel the same on both sides? Okay. Yes. Yes. The same on both sides or different? The same, okay. Yes. Yes, okay. The same or different? Good. Yes, okay. Same or different? Same. Good. Okay, great. Now, we'll move on to the sharp object here. It's not really sharp. It's not enough to puncture the skin, certainly. Can I get you to hold out your hand again? That's what sharp feels like. Okay? So, it's the same thing. I'm going to be touching you on different parts of the face, and you just let me know when you feel it. Just say yes, okay? Good. Yes. Yes. And does that feel the same or different? Okay. Same or different? Okay. Yes. Yes. Same or different? Okay. Yes. Yes. Same or different? Okay. Yes. Yes. Same, different? Okay, good. Yes. Yes. Same or different? Okay. Yes. Yes. And that last one feel the same or different? Also the same on both sides. Good. So it looks like there's nice symmetry. I'm just going to further test the finer sensory discrimination. So this time I want you to close your eyes, and I'm either going to be touching you with the soft cotton or the pointed end of the stick. And I want you to tell me soft or sharp as I touch you, okay? Good. Sharp. Soft. Sharp. Soft. Sharp. 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 Soft. 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 Sharp. Sharp. Soft. 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 And sharp. 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 Soft. Sharp. Okay, very good. That's enough of that. Having tested the sensory receptors or pain receptors on your face, I also want to test your sense of temperature. So I'm going to take this tuning fork and just place it on your cheek here, okay? Okay, tell me, does that feel hot or cold? Cold. On this side, hot or cold? Cold. Okay. On the forehead here, hot or cold? Cold. And on the forehead this side, hot or cold? Cold. Place it on the jaw down here, hot or cold? Cold. And on the jaw down here, hot or cold? Is there any difference at all in those different regions of the face? Okay, good. Okay. I'm going to take this vial of liquid and just on the cheek with it, okay? There. Does that feel hot or cold? Hot. Very good. How about this side? Hot or cold? Hot. Forehead? Hot or cold? Hot. Jaw on this side down here? Hot or cold? Hot. Very good. And over here as well. Hot or cold? Hot. And just up here. Hot or cold? Hot. Very good. Okay. Okay. Now, I also want to test the corneal reflex. That'll involve me touching your eye with this piece of cotton. Is that okay? Not gonna hurt. It's just a reflex test, okay? Good. So I'm just gonna tear it up and whistle the end so we just get the tiniest wisp of cotton right there. Okay, so can I ask you to look over here? Okay. Look over here, and I'm just gonna come in very, very gently. There. That's a blink, so that's good. Now look over here and look upwards. Okay, and I'm just gonna keep there, and that's a blink. That's excellent. So your corneal reflex is also functioning perfectly. Okay, so that's good. Okay, so I also want to test your glabella reflex. Now, allow me just putting my hand on your forehead and just tapping it lightly. Is that okay? Good. Okay. Just still, stare straight at me. Good. Nice blink there. That's all we want. Okay, so that's all done for the sensory part of the trigeminal nerve. But like we said, there's also muscles involved. First, I'm going to just put my hand on the sides of your jaw right here. And just start by just feeling around. General muscles. Quite clearly feel the muscle bundles here, the masseter, and just up here, the temporalis. So, very nice and normal. Okay, so that's good. I'm going to place my hands here, and I'm going to ask you to clench your jaws, okay? Clench and relax. Clench and relax. And clench and relax. That's good. Clench and relax. Good. Clench again. Hard. And relax. Clench a regular wooden spatula, of course, sterilized, clean. If you could open your mouth. Go and bite down. Okay, I'm gonna try to pull this out of your mouth, but don't let me. Okay, just bite down as hard as you can. There, that's excellent. You can relax and open your jaw. Great. Okay, so to open your mouth, and I'm going to place my hand on your chin here and try to close your mouth, but don't let me. Okay, so just resist my pressure here upwards. Don't let me close your mouth. 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 And relax. That's good. Excellent. Okay, just take a minute to relax the jaw. Some of these can be a bit taxing, but you're doing great. Okay, you're doing great. Now, can I just get you to open your jaw again and move it from side to side? And try the same, but in a circular motion. Up, down, and to the sides. I'm just going to listen for any joint sounds while you move it. Circular, just keep rotating the jaw, just looking here. Okay. No abnormal joint sounds there. No. The final test is a reflex test of the jaw jerk reflex. So if I can just get you to relax in your jaw, let it hang slightly open, not wide open, just relax. Like that. Excellent. I'm going to place 2 fingers right here. And I'm going to just strike my fingers, okay? Again. Good. And one final time. Good. Good. I you aced the trigeminal nerve exam test, so I'm very pleased with the results. You had excellent sensory reception in all regions of the head, the temporal, the maxillary, and the mandibular. Your chin, your jaw, your muscles of mastication, all functioning normally. So, nothing to worry about there. So, let's take a closer look at your face. Now, we already went over some of the sensations of the face, but the 7th cranial nerve, the facial nerve, actually controls quite a number of different things. Most importantly, those are the muscles of the face that allow you to express yourself in different ways. Surprise, anger, fear, joy, sadness, all the emotions you're running through on a day-to-day basis. So it supplies motor information or motor signals to those parts of the face. It's also involved in controlling the so-called stapedius muscle, which is a tiny little muscle right inside of the ears, which control the dampening of sudden loud noises. Now, the facial cranial nerve, also supplies sensory information to the anterior 2/3 of the tongue. That's the front 2/3 of the tongue, so the tip and the middle part of the tongue. We're going to do some muscle tests of the face today, where I'm going to be asking you to make different facial expressions, and then at the end we're going to perform a taste test to see if your tongue is picking up all the usual tastes of sour, sweet, bitter, salty, and umami. Now, another thing, a very interesting thing that the facial nerve does is it supplies some of the parasympathetic fibers of the body and the nervous system. These fibers are often referred to as the rest and digest system. They are really primarily responsible for relaxing the body, really slowing down. And the specific parts of the parasympathetic system that the facial nerve is responsible for are the lacrimal, nasal, and salivatory glands. So that's the production of tears and saliva primarily. And these are some of the bodily functions, involuntary bodily functions that are involved with, well, resting and relaxing the body. Although you might not think crying is especially relaxing, or salivating for that matter, but it is a fact that those are functions of the parasympathetic nervous system, and on the other hand, the sympathetic nerve fibers, they're responsible more for the fight or flight parts, when you really have to tense up the body, get ready for physical exercise. Now, all that being said, let me start by just inspecting your face in general. One of the most common disorders associated with facial nerve damage is what's known as Bell's palsy, which is a partial facial paralysis of one part of the face. It's mostly not permanent, but caused by a viral infection that will wear off in usually a couple of weeks, but can cause some discomfort and unpleasantness because it's, well, hard to speak in general. Just very unpleasant to walk around with one half of the face paralyzed, but your face looks beautifully symmetrical, and the musculature on both sides look healthy and normal. I'm also just gonna take a peek. Sorry. I'm also just gonna take a peek in your ears just to check that everything is alright. Just redness in the ear canal here, the external auditory means it's fine, and you can hear this. Good. Just gonna take a look at the other ear as well. So, and the swelling or pain tenderness. But, yeah, no, everything looks fine there. So let's start by following my lead, and can I ask you to raise your eyebrows in huge surprise. And just keep them there. That's great. looks great. Just get rid of this. I don't need it right now. Now, next, I want to ask you to close your eyes as tight as you can. Okay, close. Okay, I'm gonna put my hands on your eye, but don't let me open them. Okay, I'm gonna try to open them. Just resist. Okay, put some force, but just resist. I'm gonna put some force, but just resist. Keep them closed. Keep them closed. Keep them closed. Keep them closed. That's good. That's great. That's great. Okay, I'm gonna ask you to puff out your cheeks like that. And I'm just going to come in on either side and just poke your cheeks, but stay puffed, okay? Good. Stay puffed. And relax. Good. Doing great. Okay, can I ask you to smile for me and bare your teeth? Just keep it there, keep it there, keep it there, keep it there. Okay, now smile without your teeth. Like that. Looks good. Looks happy. Yes, it does. Okay, can I ask you to make a frowny face now? Frowny face. And I'm just all the while inspecting for symmetry and all the muscles of the face working in coordination with each other. Okay, I'm going to ask you to scrunch up your entire face now. So close your eyes, your mouth, and just scrunch it up as tight as you can. Scrunch. And relax. Just relax. Are you okay? You're looking a little pinkish. Yeah. Can be all taxing, these exercises. Now, but everything looked great. So the next thing I want to test, like I said, the taste test of the front 2/3 of the tongue. Ready for that? Great. Now, on the side table here, I have 6 different bottles. They are anonymously labeled, so as to not give you any clues as to what they are. But they are, of course, the different types of tastes that we as humans are generally able to pick up on. Sour, bitter, sweet, salty, and umami. And then the last one is pure water for control. It's also always important to have a control sample. One interesting fact, little known fact, of course, we always try to say that in culinary experiences we want to have a little bit of everything, but in fact, biologically speaking, our ability to sense bitter and sour tastes are actually part of the bodily defense functions, as these tastes, the body associate them with rotting, discomposing, and generally food that's bad for us, whereas salt, sweet, and umami, they signal sodium chloride, glucose, things that are good for us, amino acids, that sort of thing. So, yeah, it's no surprise that most people are fond of sweet things and wary of bitter things. But, each has their own taste, and indeed, for some, just a taste of bitterness is the ask you, have you been having any trouble tasting your food as of late? Not that you've noticed. No. Okay. So I'm going to be taking a dropper. I'm going to be asking you to open your mouth, stick out your tongue. I'm going to be dropping the liquid, just a few drops on the tip of your tongue. Okay? I'm going to give you just a few moments to evaluate the taste. I'm going to be asking you to identify the type of taste, sweet, salty, etc., and also the intensity on a scale of no intensity at all, slightly intense, moderately intense, very intense, and extremely intense. Okay? Good. Now let's begin. Okay, stick out your tongue. There. Can you identify that taste? Salty. Okay. And how would you rate the intensity? Moderately salty. Okay. That's good. Take another. Open your mouth, stick out your tongue. There. How is that? Sweet? Pretty sweet. How is that? Very or extremely sweet? It's very sweet. Okay. Okay. And of course, I should have mentioned at the start, being these are anonymous, I may present you with all 5 different taste types or only some. So there's no use counting the taste in your head. Okay. So next type. Open your mouth, stick out your tongue. There. How's that? Bitter. Slightly bitter. Very good. Next one. Salty. Okay. Moderately salty. Okay. Now is that sour? Extremely sour even. Alright. Let's do another one. Okay. How'd you rate that? Just take your time, it's alright. Not that intense. Could you identify the taste? Nothing? Okay. Putting down no flavor then. No intensity at all. Okay. Next one. There. Sweet. Moderately. Okay. And if you need a refresher or a glass of water, just let me know. Are you good? Good to continue. Okay. Otherwise, just let me know anytime, okay? Stick out your tongue. How's that? Slightly sour. Okay. How would you rate that? Bitter. Slightly, moderately bitter. Okay. Okay. Last one. Stick out your tongue. Okay. How was that? Not that intense. Nothing. Okay. I'm gonna write down no flavor. Okay. Sorry, it wasn't the last one. There's a few more to go here. Stick out your tongue. Okay. It's quite intense. Umami. That's one that's kind of hard to define. That's right. Also, the most recent addition to the taste types. Let's do the last one now. There. Umami again. Okay. Same intensity, I think. Okay. Good. Well, you did good. The final test is just to test your lacrimal glands, those being the tear-producing glands. And to that end, two small pieces of paper, and I'm just going to be holding these up to each of your eyes in turn, and try to do anything other than just stare straight at me. Okay, so left eye here. Just stare straight at me. I'm going to be holding it here for just a little while longer. Shouldn't be uncomfortable or anything. And what this should do is just allow me to assess the moistness of the paper after some time to check that your lacrimal glands are working properly. Okay. And there. See, that's actually nice and moist, just the right amount. Did that hurt or anything? Okay, I'm gonna do the other eye as well. So, sit still, stare straight at me. And it's the same thing. I'm just gonna be holding it slightly under your eyes to see the tear production is working properly. So can I ask you in the meantime if you've been having any trouble producing saliva, or if your mouth has been feeling excessively dry? No? No, I didn't think so. I didn't notice any troubles in that department. see there's also just the right level of moistness. So that actually concludes the test of the facial nerve, cranial nerve 7, and everything looked to be in order. You're both able to look happy, look sad, look joyful, surprised, and angry, and that's exactly what we want. And I noted that the facial nerves, parasympathetic fibers working properly and able to supply you with plenty of rest and relaxation. So that's what we're hoping for. Now, let's take a look at your ears now with the 8th cranial nerve, the vestibulocochlear nerve. You recognize those two words, two separate nerves really, but they combine into one nerve originating in the inner ear, where they control both your balance, vestibular sense, and your hearing for the cochlear. Now, like I said, they both originate in the inner ear, and from there they travel through this bony channel inside of your skull called the internal acoustic meatus. Now, a meatus is another word for a sort of pathway inside of the body. So we have the internal acoustic meatus, and we of course also have the external acoustic meatus. That's the outside ear hole, if you will. So there's an inside ear hole and an outside ear hole, and these holes are separate. They're separated by a membrane, hearing apparatus, lots of things going on in the inner ear. So even if you took a Q-tip and tried poking inside your ear, you would not be able to reach the internal acoustic meatus or the brain for that matter. They are separate, so nothing to worry about there. Now, of course, the way the hearing works is we have the eardrum or the tympanic membrane, which vibrates in response to sound waves pushing up against it inside of the ear. These vibrations are channeled through tiny bones inside the middle ear, and they eventually reach the cochlea, which is a fluid-filled canals inside of the inner ear. Cochlea, interestingly enough, is the Greek word for snail, because the cochlea is shaped like a snail. And from there, these vibrations are converted to electrical impulses or signals that are then, like I said before, travels through the internal acoustic meatus and into the brainstem. Also inside of the inner ear we have semicircular canals and what are called otolith organs, and these have to do with the vestibular nerve. These sense body movement and head position and that sort of thing, and those signals travel through the vestibular nerve in the same canal, actually the same canal also as the facial nerve travel, so there is possibly some overlap in symptoms. So that's one of the reasons why it's important to go through an extensive and detailed battery of tests for all of the different cranial nerves, so that we really get the chance to distinguish different symptoms that you may be experiencing after your trauma. Now, another thing I do have to mention about the vestibulocochlear nerve is that unlike most other sensory nerves, this nerve consists of bipolar neurons. Now we also have monopolar and multipolar neurons, but these are bipolar, which means they have two processes extending from a single cell body. One process is called a dendrite, which means it's receiving sensory information. And the other is an axon, which means it transmits these signals as electrical impulses out the other end and, eventually to reach the brain, where everything is bound together to create this fascinating web of sensory input and allow us to experience the world. Now, all that being said, I think the first thing I want to do is just to take a look at your ears. And I'm just going to take a little light here and just examine your ears, likely for infections or any blockages, okay? So I'm just inside here, your right ear. Okay, nothing to see there. That looks all good. Let me check the other side as well. So, just taking a close look here for here. Right, this one. Block just any other foreign object. Block the external acoustic means here, but there does not seem to be anything. Okay, so you're all good in that department. So let me then ask you, have you been having or experiencing any changes in hearing lately? Hearing loss, anything of that sort? No, that's good. How about balance issues? Any headaches or nausea or dizziness, anything like that? Okay. Any pain in the ears? Tinnitus, ringing in the ears, anything like that? Nothing. Okay. Well, that all sounds excellent. So I want to do a couple of hearing tests. And the first one is very simple. I'm just going to be whispering some words into each of your ears, starting really close by and then getting further and further away, and just to see if you can still hear me. So just repeat after me the phrase, word, number you hear me say, okay? So I'm beginning quite close. Is that okay? Good. Okay. 1, 2, 4, 7, 1, 41. Okay. That's fine. Let's do the other ear. Okay, you ready? 13, 17, 21, 30, 61. Okay, that seems perfectly normal. Next, I want to try the same thing again, except this time add a distraction in the opposite ear. So I'll just be taking my fingers and just rubbing them like that next to your other ear while also whispering in the same ear. So, same thing, just repeat what I say, okay? 3, 1, 4, 1, 5, 9, 2, 6. Okay, that's good, excellent. Okay, let's try the other ear. So, you ready? Good. 8, okay, that was excellent. Now let's do a couple of tuning fork tests. These are called the Weber's and Rennes test. Okay, so the first test, the Weber's test, I'm gonna strike the tuning fork and place it just right there on your forehead. Okay, and it's gonna feel quite cold, but just focus on the sound and tell me whether you hear it more in the left ear, your left, your right, or centrally, or in the middle equally in both ears. Okay, so that's it. Just tell me where approximately you hear the sound. Okay, good. That more on the right, left, or in the middle? In the middle. Okay, that's good. I just want to do one more just for control, okay? Okay, so right, middle, left, in the middle. Okay, that's good. Now, what we're testing here is, of course, if there is any hearing loss, and also if there is any, if that hearing loss is conductive hearing loss or a sensory neural hearing loss, which is primarily what I'm interested in. Most types of conductive hearing loss are actually quite simply explained by blockages of the ear canal, mainly by earwax, which is very simple to remove, whereas sensory neural hearing loss are caused by, or can be caused by, nerve damage to the vestibulocochlear nerve. But, well, according to whether it's sensory neural or conductive, you're going to get different results and hear things differently in the right or left ear. But let's move on to the Rennes test, which is going to tell me a little more about any possible differences in hearing and damage to either the left or right cranial nerves. So the Rennes test, I'm going to again strike the tuning fork. I'm going to place it on the mastoid process, which is the bony ridge right there behind your ear. You're going to hear it through bone conduction, basically, where I place the base of the tuning fork at the bone. And when you can't hear it anymore, let me know. Just tell me I can't hear it, and then I'll move it from the mastoid process and in front of your ears. Okay? And at that point you should be able to hear it via air conduction, which is typically stronger than bone conduction. Yeah. Anyway, you don't need to know how it all works. Just tell me when you hear the sound and when you don't hear the sound. Okay? Excellent. Okay, so you're right. We're going to do this ear first. Okay. Stopped. And how about now? Excellent. Okay. Now we're going to do the other ear. I'm going to place it on the bone. Just let me know when you can't hear it, okay? Stop. Now. Okay, good. Just tell me now. You can hear it. Okay, that was excellent. I'm going to repeat the test just for a control. So we're going to do your right ear again. You ready? Stopped. Okay. And now. That's it. Okay. Good. Gonna do your left ear again. Okay. Stopped. And now. Okay. Let me know when you can hear it. Excellent. Now that was all of the tests that are necessary to perform to test your hearing today. The results all looked perfectly normal. But now let's try and test your vestibular sense of the vestibular nerve, shall we? So, can I ask you to just stand up for me? Just stand up straight. Just like that. Great. Now, the first thing I'm going to ask you to do is called the Romberg test, where you'll just be standing straight up and put your feet together like that and close your eyes just like that, and then just stand still just like that. Okay. Looks good. Looks good. Just for 30 seconds, so just a little while longer. Just 10 more seconds. Keep your eyes closed and your feet together. That's great. Okay, you can open your eyes again. Okay, so what that's testing is just your basic balance, and that's what we'll be testing in all these tests. Now, it's not that taxing and not hard at all. Although standing still the first, that was the easiest of them, I should say. Okay, so now if you've regained your balance, did you have any trouble keeping your balance during those 30 seconds with your eyes closed? No, that's good. Okay, try and close your eyes again. Okay, and this time try to march, like take steps in place. So don't walk forwards, don't walk backwards, just stay in place, but march in place, okay? Just like that. Keep your eyes closed, keep them closed. Keep them closed. Okay, that was excellent. Yes, you can open your eyes again. Okay, so we're gonna do one more test of a similar kind, the Fukuda stepping test. This time I'll be asking you to take one step in place and then turn 180 degrees. So turn your back to me, then take one step in place, turn again, one step, turn, one step, turn. Once at a time until I tell you to stop. And just take your time, don't go spinning around like a maniac, okay? Right, we don't want that. Okay, so again, just stand up straight, close your eyes. Okay, and take a step and turn around. Step, turn around. Very good. Step, turn around. Okay, step, turn around. Good. Step, turn around. Step, turn around. And the final one, step, turn around. Okay, and you can open your eyes again. Okay, that's good. So the reason I keep asking you to close your eyes is because, well, the visual sense, of course, also helps our body to, maintain awareness of the place we're in and the place our limbs and our body are in. But the vestibular nerve, by closing your eyes, we're testing the proprioception, the body's own self-awareness, if you will, of its position in space. Okay, so that's why we're trying to eliminate other senses. As you know, we've already tested the optic nerve. We know this working properly and well. Now we're testing the vestibular nerve, and the next thing we're going to do is called the past pointing test. Okay, I'm going to stretch out my arms like this. If you could stretch out your arms as well, just so that our fingers are touching right there. Okay, that's excellent. Okay, now you can keep your eyes open just for a second. Now raise your arms up like that. Okay, raise them up and bring them back down again so that our fingertips are touching. Okay, just like that. Very good. Okay, now close your eyes and do the same thing again. Okay, our fingertips are touching. Raise your arms. Okay, that's good. And bring them back down just to where, yes, that's right. Fingertips are touching. Okay, try it again. Raise your arms. That's good. And bring them back down to my fingers. That's excellent. Great proprioception. Okay, one more time. Raise your arms. And bring them back down again to my fingers. Like that. That's excellent. Okay, let's do it again. Keep your eyes closed. Raise your arm. And bring them back down again to my fingers. Just there, touching. That's great. Great sense of space. Let's do it one last time. Raise your arms. Keep your eyes closed. And back down my fingers. There we go. Excellent. Good job. You can open your eyes again. Okay, so there's just one more thing I want to try, okay? And this is to test for nystagmus, which is an involuntary jerking of the eyes and shifting focus. So I'm gonna place my hands on your face. Can I do that? Okay. And then I'm gonna grab like this, and then I'm gonna turn your head to one side quite quickly. Like that. And like that. It's not gonna hurt. Don't worry about that. I'm not gonna force your neck. Just gonna turn your head, okay? Don't resist me anything, just turn your head with my hands. But at the same time, I'm gonna be asking you to stare at me, stare at my nose, and keep your eyes focused on my nose, even while your head jerks to one side, okay? Okay. So I'm just gonna place my hands here, and then keep your gaze fixed on my nose while I jerk. There. Okay. It's good. And I'm just watching and observing your eyes while I do. Okay. 3, 2, 1. There. Good. 3, 2, 1. The other side. And this time again. 3, 2, 1. Okay. 3, 2, 1. Okay. Other side. 3, 2, 1. Okay. Great. Maintaining fixed gaze there. That's excellent. Now, let me just make a note of that. So, we've been testing the cochlear nerve, the hearing, the Rennes, the Weber's tests, whisper test, and we've tested your balance, the Romberg, pass pointing, and we tested for nystagmus, and all of those tests revealed nothing wrong. So I'm pretty confident in saying that your vestibulocochlear nerve is working as it should be. So the internal acoustic meatus is free and clear for the nerve to travel through. Nothing impeding it, nothing stopping it, nothing poking at it on its way there into your lovely brain. Now, that so glossopharyngeal and vagus nerve. Let's go. Now, you might be wondering if we aren't going a little bit too fast, covering 2 nerves in one go. But the same as it was the case with the Oculomotor, Abducens, and Trochlear nerve, where we covered 3 nerves in one go, all related to eye movement, the glossopharyngeal and the vagus nerve are actually very closely related, both physically. They travel along some of the same bodily channels, and they're also very closely related in their function and how they affect our body, our senses, and motor information. So, well, I thought we'll take them one by one, even so, starting with the glossopharyngeal nerve. The glossopharyngeal nerve emerges from the medulla oblongata in the brainstem, then travels down to the jugular foramen, but before exiting the skull, it has 2 sensory ganglia, or collections of sensory neurons, the superior glossopharyngeal ganglion and the inferior glossopharyngeal ganglion. Now, then, after exiting the skull, it branches out to innervate its target areas, these being the pharyngeal muscles, namely the stylopharyngeus muscle, which helps elevate the pharynx during swallowing, and it's also involved in regulating our speech. Another target area is the posterior third of the tongue, which it supplies sensory information to and from. So the very back of the tongue is actually controlled or maintained by the glossopharyngeal nerve. And finally, it also supplies parasympathetic fibers to the parotid gland, which is one of our salivatory glands, so involved in saliva production. Now, you might remember us talking about the parasympathetic system earlier, and we will get back to that because the glossopharyngeal nerve is involved in that, but more especially the vagus nerve. Now let's touch on the vagus nerve. Similarly to the glossopharyngeal nerve, it emerges the same place. The brainstem travels down the same pathways through the jugular foramen at the base of the skull, then all the way down to the throat, thorax, and abdomen to innervate many, many different organs of the body. Now, the vagus nerve, traveling all that long way, is actually the longest and most extensive of our cranial nerves. It also has the nickname the wandering nerve, vagus being Latin for wander. Some of the organs that are touched by the vagus nerve include the esophagus, intestines, stomach, heart, lungs, liver, pancreas, and many more. So it is extensively involved with the parasympathetic nervous system, helping the body relax, slowing down heart rate, helping the digestive process, also the inflammatory response is helped by the vagus nerve, bowel movements even. So many different and important areas are maintained by the vagus nerve. The vagus nerve, like the glossopharyngeal nerve, also supplies motor information to the pharynx and larynx, so it helps with swallowing and speech. And it also has a sensory component. Interestingly enough, from the internal organs, actually, it has information from the baroreceptors and chemoreceptors in the aorta, helping to sense oxygen levels and blood pressure. So some interesting senses, not the same kind of sensory information as eyesight or hearing or outside touch and pain receptors, though there's also some of those, namely around the outer ear, and as well as the ear drum. So even though the skin is one organ and there are pain and touch receptors all over our skin, all over our body, different parts of the skin and the body is controlled by different cranial nerves, and the vagus nerve, funnily enough, it has sensory information from the outer ear and eardrum, like I said. So, having been through all of that, I'd like to ask you some questions and about possible symptoms that may indicate damage to either the glossopharyngeal or the vagus nerve. So, let's start with taste. Have you been experiencing any difficulty or any changes with your sense of taste? Specifically at the back of the tongue, but any changes at all that you noticed? No. Good. Any pain or tenderness in the tongue at all? So have you in general experienced any decreased sensitivity, either at the back of the tongue, the palate, uvula, or generally just inside of the mouth? Okay. Any dryness, dry mouth? Okay. Any irregularities in your gag reflex that you've noticed? Okay. Have you had trouble swallowing or any pain while swallowing? Okay. And have you been coughing after eating or drinking? No? That's good. Have you had any heart rate issues? Like irregular heart rate where you wouldn't normally have experienced such a high or low heart rate? Okay, any gastrointestinal problems like ulcers, heartburn, indigestion, irritable bowel movements, anything like that? Okay, well, that all sounds good. So let me just get rid of these and just look inside of your mouth. Okay, so I have my light once again. Can you just open your mouth for me? Okay. That's good. Okay, now can you open wide and say ah? Open wide. That's good. You can stop now. That's great. Thank you. So, it's just assessing the soft palate, the uvula, looking to see that everything was symmetrical and raising equally when you enunciated, which it did. So your mouth on the outside looks fine, and there are just a few more tests that I'd like to do just to be as thorough as possible. Now, this next test might be just a tiny bit uncomfortable, okay? I'm gonna try and activate your gag reflex. Yes, it'll only be a moment. So if you can open wide, I'm gonna insert the tongue depressor in your mouth and just you. There we go. Okay, I'm sorry. Now, but that is it. We're done with that. Okay, so can I just get you to cough for me? Sounded good. Strong, explosive cough. Okay, I'm gonna touch your neck. Is that okay? Okay. Now, cough again for me. Good. Just your chest here. Cough again. Good. No, that's fine. Now, have a glass of water, or just one single sip will actually also be fine. But keep it in your mouth. There. Good. And swallow, please. Was that alright? That feel regular? Good. Okay, I want to continue with a voice quality test, and I know we've been having a nice conversation, so it really might not be all that necessary, but still I'd like to stick to the test as written and be, like I said, as thorough as possible. You never know what could come up. So, just locate test here. So, I have a couple of sentences that I would just like you to repeat after me, okay? So, here's the first one. Imagine an imaginary menagerie manager managing an imaginary menagerie. Very good. Okay, next one. A skunk sat on the stump and thunk, the stump stunk. But the stump thunk, the skunk stunk. Very good. Now, number 3. Betty Botter bought some butter, but she said, this butter's bitter. If I put it in my batter, it will make my batter bitter. But a bit of better butter will make my batter better. Butter better. Yes. That's right. Okay, so enough with the tongue twisters. The next one is a dictionary definition. It's quite a long one, so I'll just take it one sentence at a time and you repeat when I signal, okay? So the definition is for the word heart, very relevant to the vagus nerve. Noun, an automatic muscular blood pump. Figuratively, this useful organ is said to be the seat of emotions and sentiments. A very pretty fancy which, however, is nothing but a survival of a once universal belief. Good. It is now known that the sentiments and emotions reside in the stomach, also relevant to the vagus nerve. Stomach. That's right. Being evolved from food by chemical action of the gastric fluid. Good. The exact process by which a beefsteak becomes a feeling, tender or not, according to the age of the animal from which it was cut. The successive stages of elaboration through which a caviar sandwich is transmuted to a quaint fancy and reappears as a pungent epigram. The marvelous functional methods of converting a hard-boiled egg into religious contrition. Or a cream puff into a sigh of sensibility. These things have been patiently ascertained by M. Pasteur, and by him expounded with great lucidity. Very good. No, you're right. It wasn't a normal dictionary. You got me. It's actually from the Devil's Dictionary. Now, the last test that I want to do for the glossopharyngeal and vagus nerve is a taste test. Now, you might say we already had a taste test, didn't we, when testing the facial nerve? And you're right, but that test was only for the tip of the tongue, or the anterior 2/3 of the tongue. Now we are testing the posterior third of the tongue, so the very back of the tongue. But the test will be conducted in much the same manner as before. I will take a dropper and just place a few drops of tasteful liquid at the very back of your tongue, and you will evaluate whether it is sour, bitter, sweet, salty, or umami and also how intense the taste is. Okay? Good. Let's get going. So, now, same as before, we have the different tastes here. If you could just look at me, and I will start. There we go. Now, stick out your tongue as far as it will go. Okay. What taste would you describe that as? Bitter. Okay. I'll mark that as bitter. Moderately intense. Okay. Next one. Okay. Stick out your tongue as far as it'll go, and this will be at the back. Okay. And how would you describe that taste? Salty. Very salty. Okay. Okay. Another one. Sweet. Okay. Slightly sweet. Okay, take out your tongue. Salty. Again. Okay. And moderate again. That's fine. This one here. Okay, stick out your tongue. There. Umami. Okay. Very intense. Good. Next one. There we go. Nothing. Just no intensity and no flavor. Okay. Okay. Just a couple more. Go. Stick out your tongue and let's go all the way to the back of the tongue. There we go. Okay, what was that? Bitter. Slightly intense. Okay. This one. There we go. Stick out your tongue. Good. Sour. Okay. Moderately. Okay, final one. Stick out your tongue. There we go. How would you rate that? No flavor. You're right, that was just water. Would it very intense water taste for you or moderately? Just kidding. Though I shouldn't, you know. that was all of the tests that I wanted to do in relation to the glossopharyngeal and the vagus nerve. Though I did here at the end want to discuss a few tips and tricks and techniques that you can do at home to actually help stimulate the vagus nerve. I talked about it being, the center of the rest and digest, the parasympathetic nervous system, the relaxation of the body and all that. But actually, by stimulating, some believe that you can help to relax the body by different means. One of these is a very common, it's deep breathing. But after hearing about the vagus nerve, you may have a better understanding of why and how this is supposed to work. Deep breaths in through your nose, all the way down into the lungs and the stomach. Deep breaths in through the nose, all the way down into the lungs and into the stomach, really filling them up with air, all the areas that are innervated by the vagus nerve, and then slowly breathing out through the mouth. Again, the mouth being innervated by the vagus nerve, responsible for relaxing the body. So that's why deep breaths, really filling the body with relaxing air, blowing it out ever so slowly, might actually be able to relax the body in a factual way. Another way you can stimulate the vagus nerve is by touching some of the areas where the nerve supplies sensory information, like the ears. You remember me saying they supply sensory information to the outer ear as well as the eardrum. So if you need to relax your body yourself, you might find it useful to just rub gently along the edge of the outer ear, very gently and slowly. No pressure is needed here. You're just stimulating the nerve very softly. You may also try to rub the skin at the back of the ear, either in circles or up and down. Just pull the skin up and down, up and down, just very, very slowly. Though medically proven, there's still a lot of work on the science and experiment front to be done. These techniques have shown some positive signs of actually working, and I've heard good stories and had good experience with them from patients. So I'm not afraid to recommend them to you if you sometimes feel that you could use a bit of extra relaxation in your life. And let's be honest, in this world, who couldn't? But yeah, like I said, that concludes the test of your glossopharyngeal and vagus nerve, and everything across the board, tip-top shape. So, shall we take a look at your accessory nerve now? Great. So, as you know, this is cranial nerve 11 out of 12. So, not much more to go. We're almost done with the exam, so just sit tight and relax. You've been doing great all this time. And, just a few more tests to go. So, before we begin the testing, I want to tell you a little bit about the accessory nerve so that you know what we're dealing with. And the accessory nerve, the cranial nerve 11, is actually quite interesting. It is, in fact, the only cranial nerve which has its origin outside of the brainstem, outside of the cranium, the skull. And well, you might ask then, why is it even part of the 12 cranial nerves if it's not in the cranium? Well, it is and it isn't. So there are two components to the accessory nerve. The spinal component, the spinal accessory nerve, and the cranial component, the cranial accessory nerve. And the cranial nerve, the cranial accessory nerve, does originate in the brainstem and the medulla oblongata, same place as the vagus nerve, which we just examined. And in fact, it innervates many of the same muscles as the vagus nerve, the larynx, the pharynx, the soft palate, helping your body, your mouth, swallow, and speak primarily. So that's the cranial part of the accessory nerve. But there's also another part, like I said, the spinal component, the spinal accessory nerve, and that originates outside of the cranium, down here at the first 5 or 6 cervical vertebrae in the spine. Here there are a bunch of nerve rootlets and nerve fibers. They travel up along the spine and they enter the skull via the foramen magnum. And I can actually show that just a moment. The skull here. Of course, here we have the cranium, and beneath we have various openings for the cranium. The large part here, that's actually the foramen magnum, magnum meaning large, so it's quite obvious this is the biggest opening into the skull. And it makes sense. This is where the spine goes, so this is where the spinal accessory nerve comes out. And it travels up, ascends through the spine and into the skull, the brainstem, the medulla, where it meets the cranial part of the nerve, the cranial accessory nerve. Then they travel down through the jugular foramen, that's these holes here and over here, so 2 smaller holes in the skull at the base of the skull. And, well, like I said, the cranial accessory nerve travels along with the vagus nerve along the same channels and into the mouth. So, put your back in place. There we go. Now, that's just a little fun part there. It's been sitting at my desk so long, I probably should have shown it to you earlier, but there you have it. Foramen magnum. If you've learned nothing else, then you at least know there's a giant hole in the skull where the spine goes. So, that's interesting. So, what does the accessory nerve even do? Well, I talked about the cranial part, or the cranial component, that innervates the same kind of muscles as the vagus nerve. The spinal component, though, it has 2 primary functions, or 2 muscles it innervates. There is the sternocleidomastoid muscle, which is the muscle in our neck that helps us turn our head from side to side and up and down, and then the trapezius muscle, which helps us shrug our shoulders. So damage to the accessory nerve can cause neck pain, shoulder pain, or generally muscle pain in that area, because if there is damage in either the trapezius or the sternocleidomastoid muscles stop working or fail to work optimally, then other muscles in the same area may try to compensate and take over some of those functions, even though they're not really used to it and built for it. So that can cause some pain. So let me just start by asking if you've been feeling any pain at all in your shoulder area, at either left or right or both, in your neck, on either side, on the back. Nothing at all. Okay, well, let me just take a closer look here at your shoulders and your neck. So, is it alright if I touch your neck and your shoulders? Thank you. Just want to palpate just ever so lightly. Just up and down. Just assessing the bulk and tone of the muscle. And there, the feeling along the sternocleidomastoid muscle. On your neck. It's good. Okay, any pain when I touch? Okay, good. If there is any pain, just let me know as usual. Okay. Okay, just the other side here. Feeling along the muscle here in the neck. Okay, any pain? Good, good, good. Okay. Okay, just grip your shoulders here. Just relax, just relax. We'll get to the exercises in a bit. Right now I just want to assess the muscles up here. Let me just check the back as well. That's good. And the other side. That feels good and healthy. And I'm just assessing the scapula here at the back. Doesn't seem like there's any unnatural protrusion of anything. A winged scapula. So, that was all great. Okay, so let's do just a few very, very easy tests. Well, should be easy if there are no nerve damages to the accessory nerve. So, first things first, can I ask you to raise your shoulders up like this? And I'm going to place my hands on your shoulders and try to raise them again, and don't let me push you down, okay? Raise, 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 and resist. Resist, really resist my touch. Resist, really resist my touch and my pressure, okay? Resist, resist, resist. Okay, that's great. You can relax. You can relax, okay? Shake your shoulders. That's great. Okay, now raise just this shoulder here. That. Very good. And raise the other shoulder here. Like that. Great. Okay, I'm going to put this shoulder here. Try to raise it. Very good. Now, same thing on the other side. Raise this shoulder here. Good. And now raise it over here. Very good. Very good. Okay. Just sit back. Now, take your arms straight out in front of you and lift them up. Straight up in the air. Don't bend your arms, just lift them straight up as high as you can. Okay? Yes, that looks good. Any pain with that? Okay, good. You can lower your arms again. Good, like that. Okay, now let me move it back for the next part. Okay, so I want you to just sit quietly and comfortably and relaxed in your chair with your arms bent at the elbows, your hands in your lap. Okay, just like that. Okay, then take your hand, bend it out to the side like so. Okay, and then try lift it up like this. And I'll just feel along your forearm while you do that. Okay, try and lift it. Okay, just lift it up, don't let me push you down. Great. Okay, now bend it to the side. And then move it inwards like that, okay? And I'm just feeling along the muscles here. Okay, bend it inwards. Don't let me push you away. Very good. Okay, stretch and bend again. Inwards and resist. That's good. Okay, relax that arm. Now do the other arm first. Move it outwards like so. Okay, and I'll just feel along here and try to resist a little bit. Put some pressure there. Bend outwards. That's great. Okay. Now try to bend up again and again. Don't let me push you down. Just resist. Okay, so that's great. I want to check the reflexes of your arms. So for that, I have this small reflex hammer that we've been using previously. I'm going to just tap very lightly on different places along your shoulder, your elbow, and your wrist. Okay? Okay. So again, just sit relaxed with your arms, or your hands rather, in your lap. Okay? Good. Okay, so I'm going to go over here, and I'm just going to tap right here along the upper bicep. Okay, that's good. Move down here, the elbow. Good. And the wrist down here. Very good. Okay, we're going to do the other side here. Upper bicep, shoulder. Good. Long down to the elbow. That's good. And now the wrist here. Good. 7, 5, 6. All working properly. So that's great. So another test I'd like you to do is just try to roll your shoulders forward. Okay, like this. Very good. Now try to reverse the motion and roll them backwards. Like so. That's very good. Okay, now raise one shoulder and lower your head at the same time towards the shoulder. And now do the other one over here, like that. Okay, any pain with that at all? Okay, I'm just going to put a hand on your neck here on this side. If I could ask you to turn your head this way, and I'm just feeling the sternocleidomastoid muscle flexing when you do that. So when you're moving your head this way, it activates this muscle, and when you look that way, it activates over here. Okay, so if we saw any difficulty in moving your head one way or the other, it would indicate damage to the contralateral side. Contralateral accessory nerve. So we know there are pairs of nerve and pairs of muscles here in the neck. On the other hand, failure to, for example, lift one shoulder, that indicates that the accessory nerve on this side is damaged. Okay. Of course, it can be damaged on one side, the other side, or both. Typically, if the problem is further up. But the accessory nerve is one of the cranial nerves and spinal nerves that is actually quite often exposed to damage in physical sports like football or soccer, any other sport where there's physical contact between people, martial arts, combat sports, etc. Lots of things can cause damage to the accessory nerve and cause difficulty, raising the arm, raising the shoulders, turning the head, and just causing general pain. And that can be caused by lots of different things. It doesn't have to be nerve damage, but it can be. So, figuring that out can sometimes be a bit of a challenge. And that's why, people can go to all sorts of medical professional, physiotherapists, chiropractors, massage therapists to try to alleviate pain or cure problems or illnesses related to the muscles, the trapezius and the sternocleidomastoid. And sometimes it helps and sometimes it doesn't, and then you have to, get a doctor to check you out because you may have accessory nerve damage. Okay, but on the face of it, it doesn't look like there's no indication of any nerve damage so far on you. I do want to check a few more things related to the sternocleidomastoid muscle of the neck. Okay, so I'm just going to place my hand here, and then I'm going to ask you to turn your head towards my hand against the resistance. Okay, don't let me push you, just turn the head. Turn the head, try to turn it. That's good, and you can relax. Okay, any pain or discomfort there? Okay, good. No, it felt strong, felt hotly. Okay, we're going to try the same thing on the other side here. Okay, turn your head towards my hand. Okay, turn, and don't let me push you, Okay, that's great. Okay, so that muscle seems to be functioning properly. Can I ask you to just look down for me? Down into the ground. That's right, and look up into the ceiling. Okay, any pain with that at all? Okay, good. Now just stare straight ahead. Okay, I'm going to put my hand on top of your head, like so, and I'm just going to push down using just a bit of force there. Any pain when I push down on your face? Can you feel any tension in your neck or your shoulders when I push here? No? Okay, no troubles there. It doesn't hurt or anything? Okay, that's good. So that was the cervical spine compression test, but since you did not experience any pain and you responded well to all the exercises, it doesn't seem like there are any problems with your accessory nerve, either the spinal component, which is what we've mainly been testing, or the cranial component, which we went through when we checked your vagus nerve. So, good job on that. So, the time has come for cranial nerve 12, the hypoglossal nerve. And the hypoglossal nerve is all about your tongue. That's right. The hypoglossal nerve is a pure motor nerve controlling all the intrinsic muscles, meaning the muscles that control the shape of the tongue, and the extrinsic muscles, which are the muscles that connect the tongue to other tissue and other parts inside of the mouth and control the movement. So I'm gonna take a look at your tongue in just a bit. You don't have to stay it out just yet. But the hypoglossal nerve, the cranial nerve 12, it arises deep within the brainstem, like the vagus nerve, the accessory nerve, and the glossopharyngeal nerve in the medulla oblongata. From there, it travels down the brainstem through a hole in the skull called the hypoglossal canal. So it has that canal all for itself, the hypoglossal nerve does. It then travels down right in between the carotid artery and the internal jugular vein before coming to the tongue, where it really works its magic. And here inside of the tongue, it innervates quite a few muscles. Like I said, the external muscles called the genioglossus, styloglossus, hyoglossus, and the intrinsic muscles, the superior longitudinal lingual, the inferior longitudinal lingual, the transverse, and the vertical muscles. So these are all the primary muscles of the tongue. And there's also something called the palatoglossus, but that's innervated by the vagus nerve. So that's, well, strictly not relevant. It's kind of hard to distinguish and separate all of the different parts of the body of the tongue in this instance. And that's why we're going through all of the cranial nerves so slowly and so methodically to separate out all possible symptoms and problems that we may find. So hypoglossus is actually Greek for under the tongue, which is quite fitting for a cranial nerve that strictly focuses on the tongue. But being that it has such a strict focus, damage to the hypoglossal nerve can also cause quite a few problems and difficulties with the tongue. If you have, trouble moving it around, it's called dysarthria. So maybe you have trouble moving it around inside of the mouth, sticking it out straight. We can sometimes see that, and if you try to stick it out straight and it deviates to one side, that does indicate damage to that side of the nerve. As we talked about, all the nerves are paired, so always symmetrical inside of the body, always two sides to every nerve, not just to every coin. You can also experience muscle fasciculations or twitching in the tongue, or in general problems chewing or swallowing. Of course, those symptoms can also be attributed to the glossopharyngeal and the vagus nerve, even the accessory nerve to some extent. But we've already went over those. But can I just ask you quickly, have you experienced any trouble with your tongue in general? Any of the symptoms I just described that ring a bell to you? Okay, that's good. That's good. Nothing of the sort that you can think of right now. Well, I guess that's enough talk for me. I can imagine that you just want to get on with it and get out of here, really. So there's just very few, very simple tests for the hypoglossal nerve that we'll be doing. So I'm just going to put closer to you and can ask you to open your mouth. I know I've taken a look at your mouth before, but just in general. Okay, and stick out your tongue for me. Just nice and centered if you can. That's great. I see no deviation to either side. Okay, can you move it this way here? That's great. And the other way there. Okay. Can you make it nice and wide? Can you make it skinny and tall? Okay. Okay, now as far out as you can and point the tip if you can. Okay, and now back inside your mouth. Just lay it flat like you would. Don't think about how to position it. Yes, just like that. Okay, now I'm going to be touching your cheeks. Is that alright? Okay, so close your mouth again and stick your tongue out and touch the inside of your left cheek here. That's good. Okay, now do the same with the right cheek here. Okay. No. Yeah, that was great. That was great. Okay, so nothing seems to be awry on the face of it there. So this is the last thing that we'll do today. I'm just going to ask you to make a series of clicking noises first. Let's just do a plain alveolar click, like a horse trotting. Like that. Okay? Yeah, you can start. Get about a dental click if you close your teeth. Okay, so that's done by tapping the tongue, and you couldn't. Doesn't sound quite right if you try it like this. Okay, that's done by closing your teeth, opening your mouth slightly. Just okay. That's actually just a tiny bit troubling and a bit unusual. Can you do a bilabial click? That sounds like a kissing sound. Mwah. 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 Purse your lips. Mwah. Okay. No, that doesn't sound quite right. Can you whistle? Never learned how to whistle. Okay. Can you maybe do a trill for me? Like the Spanish R sound where you sort of flutter your tongue up against the roof of your mouth. Like a cat purring, perhaps. Like that. Can you make that sound? Can you do that high or low? Okay. Can you do any sort of fluttering at all? It's like a trill, but just slower. Okay. Okay. Okay, so a few more questions. That's quite unusual. Have you had a stroke in the past month or even before that? No. Okay, I should think that you'd mention that by now if you had, so that's good. Okay, we know you suffered the trauma to your head. Are you taking your vitamins? Or have you had your vitamin levels checked recently? You have, and they're all fine. They did that? Okay, the nurses did that before the test. This is good. Okay, so because potassium levels, especially and calcium levels, can affect tongue movement, but can't be attributed to any of that then. And you haven't had any oral surgery, jaw, tongue, cavity, dental work even that we haven't noted in your file. You haven't. Okay. And you haven't had any serious infections in the recent past? No. Just that trauma. Okay. Well, I'm asking you this because, well, trouble with the tongue doesn't have to be neural damage, nerve damage. It can be, doesn't have to be. Okay. So nerve damage is the most serious kind, and it can be quite hard to treat in certain cases. But if it was an infection, for example, we would expect to see problems like this go away with time. But nerve damage can be quite a different beast. But don't worry, even if it is nerve damage, it can also go away naturally over time. The lack of clicking and fluttering of the tongue, I think I could refer you to a hypoglossal physiotherapist, one who specializes in tongue movement. Normally they deal more with speech therapy, swallowing therapy, helping stimulate those muscles, because those types of damages are more common. Okay, but they could also help you get those detailed movements of the tongue back again. Yeah. Could you ever be an ASMR artist if you can't do a click? I'm afraid I can't. I don't know. I mean, maybe. I know a lot of people do that. You've always wanted. Okay. Look, I don't think that nerve damage should stand in the way of your dreams. So if you want to do that and you can't click your tongue, I think that's fine. I think you can still pursue that if you want. Okay? Yeah. No. Look, listen, that should be the least of your worries right now, if you can be an ASMR artist or not. Okay? Don't worry about that right now. What I'm gonna do is I'm gonna write you a referral to a hypoglossal physiotherapist, same clinic, so you just make an appointment there and you can, and it'll be done the same place as here, okay? Yeah, so let me just make a note of that. Do that later. No, there's no waiting list, so I expect you can get an appointment in a day or two, or whenever it suits you, okay? Yeah. You aren't taking any medications that we haven't already talked about, right? Okay. No, I didn't think so. Okay. Could you just open your mouth again? Okay, and try to lift your tongue up to the roof of your mouth. Okay, you can do that fine. I was just wondering if it could be ankylosing. Say shorten the lingual foramen, that's the tissue connecting the tongue to the base of the mouth, the floor of the mouth. That can sometimes cause trouble with movement dysarthria, but it seems that movement was not a problem for you, so it can't be that. That's quite a bit on the mind. It's really quite an interesting case generally. Okay, so that's us all done with the cranial nerve exam for today. So we went through everything from 1 to 12, from A to C. We tested your olfactory nerve, no problems there. We tested your optic nerve, no problems there. We tested your oculomotor, abducens, trochlear nerve, eye movement, no problems there. We tested your trigeminal nerve, the sensations of your face, everything is perfect. The facial nerve, the facial expressions, no problems there. We tested the vestibulocochlear nerve, your hearing and your balance, no problems there. We tested your glossopharyngeal, your vagus nerves, all the functions of your throat, speaking, swallowing, no problems there. The accessory nerves, the muscles of your shoulders and neck, no problems there. And finally, then the hypoglossal nerve. I want to say no problems, but yeah. There were some problems with the clicking sounds and the fluttering sounds that you could not perform with your tongue. But like I said, it's really nothing to worry about, and we can definitely get a physiotherapist to help you with that, okay? So, out of all of the possible symptoms that you might have experienced after a trauma like you went through, I think a lack of tongue clicking and tongue fluttering is probably quite minor. Would you agree? Yeah. And I don't mean to diminish the symptoms. I do acknowledge that it is a problem, but it's fixable. I'm sure of it, okay? So, like I said, I'll be referring you to a physiotherapist afterwards. And, yeah, other than that, I would just like to thank you sincerely for going through all of these many tests with me. It was an outright pleasure for me, okay? Yeah. And I hope it wasn't too bad for you too. Okay. That's good. Okay, so it's getting late. I'll let you go now. Just take care of yourself, okay? And I'll see you later. Okay. Yeah. I gotta pack up too as well. See ya.